Oh, there. Okay, well, it was my seat, so we'll go. I'll have to go on memory. Okay, good morning, everybody. Hello, hello. I just have a couple of announcements before we get started. Hot off the presses, we wanted to share with you a one-page summary that we've created that showcases, and the slide that was up here was also showing it, to showcase MIHF's capabilities and expertise. You can see that the slide is an example of content that was designed to represent the value of MHIF as a leading research partner is what we were trying to highlight. So we highlight like the number of TAVR cases we've done and hours of education, just a lot of facts that are valuable to our commercial partners. We're excited to have this ready for ACC and other future uses. We have copies to share with you. There's some on the back table out there, and then there's some out on the registration table if you'd like to pick them up. I will also be sending an electronic copy to the physicians and to the research coordinators, so the research coordinators can help get the physicians help the physicians get the electronic copy. And so we appreciate it very much. And with that, I'm going to turn the microphone over to Dr. Harris for introductions.
Okay, good morning. Thanks for coming. I think we have 4 presentations today, and if I understand correctly, 3 are posters, and then Nick's is a moderated poster. We're going to start with cardiac arrest and cardiogenic shock in STEMI. This is by Claire Donovan and Ben Johnson, Scott Sharkey, Tim Henry. I think we'll see all the authors on a subsequent slide. So I've known Claire for a while. She's a native of Alexandria. Her dad is one of our was one of our senior echo techs for many years, great advocate for Minneapolis Heart Institute. And Claire shadowed me many years ago in Alexandria. She's a senior at the University of Minnesota. She's worked here as an intern. She's applying to medical school. And then Ben Johnson, of course, one of our fellows, native of Thief River Falls, senior fellow now, and we will be sorry to see him go and join our competitors in St. Cloud. But anyways, they're going to work together on this presentation. Is that right?
Well, thank you everyone for coming this morning and battling the weather and daylight savings time to be here. We sure appreciate it. Thank you for the opportunity for us to share our research and get some input from you all. Like Kevin Harris said, this is Claire. It's been a real pleasure to work with her. She was one of the interns last summer. She's done a great job with the acquisition and the analysis of this data. And based on all my experiences, she really has a bright future ahead of her in medicine. So without further ado, Claire, tell everyone about our project.
Thank you, Dr. Johnson. So again, today we're going to be talking about cardiac arrest and cardiogenic shock in STEMI. This is just an overview of our poster that I'll be presenting Saturday morning at ACC, and we'll kind of dig into it today. So the title of our work is Influence of Cardiac Arrest and Cardiogenic Shock on Outcomes Among 4,500 Consecutive STEMI Patients. And I've done this work, and I could not have done it without the help of Ross, John Hibbs, Dr. Larson, Dr. Henry, and Dr. Sharkey, as well as Dr. Johnson. So a little bit of background. Previous research has shown that cardiac arrest complicating STEMI is associated with significantly increased mortality, and outcomes may differ whether the arrest is shockable or non-shockable. And outcomes may also be influenced by the presence of cardiogenic shock. So our objective of the study was to examine outcomes among STEMI patients presenting with cardiac arrest with or without cardiogenic shock. So we took prospective data from the Level 1 STEMI program, which you are all familiar with, and we examined patients from March 2003 to December 2014. And we stratified these patients based on cardiac arrest, shockable or non-shockable, and the presence of cardiogenic shock. And we examined patient characteristics and mortality data for these different groups. So from March 2003 to December 2014, we had 4,511 consecutive STEMI patients in the Level 1 database. And this first table here, we look at some of the patient characteristics. Among this entire cohort, the incidence of cardiac arrest is 11%. In shockable arrest, we had 441 patients, which is 9.7% of the entire cohort, and 156 of these had cardiogenic shock. In non-shockable arrest occurred in 58 patients, which is about 1.3% of the population, and 29% of these individuals had cardiogenic shock, which is 50% of those non-shockable arrests. And then our reference population were the 4,012 patients who did not have arrest, but the presence of cardiogenic shock in this group was 5.3%. Some of our significant findings: the ejection fraction in shockable arrest patients was significantly lower in those with cardiogenic shock, which can be expected. And the hypothermia protocol was also used more prevalently in those with cardiogenic shock. This table here, we're looking at the lesion characteristics of the culprit lesion. We just wanted to point out that across all patient groups, the LAD and RCA are about equally represented at about 30% prevalence as the culprit lesion. And then we also wanted to point out that non-proximal stenoses were present in 35% of cardiac arrest patients and 33% of cardiogenic shock patients. So a good portion of these patients did not present with solely a proximal lesion, which we normally put more emphasis on. Here we look at arrest location, length of stay, and mortality. 43% of arrests occurred pre-hospital and 34% in the initial emergency department. So 77% of these arrest events in STEMI patients occurred before Level 1 transport or before arriving here at Abbott. The length of stay was significantly longer in shockable arrest patients who had cardiogenic shock, which again could probably be expected. And then our mortality results, among these 4,511 patients, 250 patients died in hospital, which is a 6% of the population. Of those who died, cardiac arrest was present in 56% and cardiogenic shock was present in 53%. So overall, cardiac arrest and or cardiogenic shock accounted for 76% of all in-hospital deaths. In looking at shockable arrest, patients who had cardiogenic shock had 2.8 times higher in-hospital mortality. However, in non-shockable arrest, in-hospital mortality was equally high in those with and without cardiogenic shock. So with these figures, we wanted to look at the data a little bit differently. We looked at patients whether they had cardiogenic shock or not, and then we compared the patient groups between the arrest, whether they had shockable arrest or non-shockable arrest. So the figure on the left here, these are patients who do have cardiogenic shock, and we compared shockable to non-shockable arrest. And in this group, there are significantly more males in the shockable arrest group, and then there's a trend towards more smokers in the non-shockable group with a p-value of 0.069. And then on the right, we have our patient groups who do not have cardiogenic shock. And again, there are significantly more males in the shockable arrest group, and then there is a trend towards more proximal culprit lesions also in the shockable group. And these figures here, we have the Kaplan-Meier survival curves with and without cardiogenic shock. On the left, survival with cardiogenic shock, you can see, is pretty dismal, where only 50% or less survive regardless regardless of their arrest type. But please note that the majority of this mortality occurs in hospital. So if the patient survives to discharge, they have a pretty good prognosis. And then on the right, we have survival without cardiogenic shock. And you can see that survival is significantly better without cardiogenic shock unless you have a non-shockable rhythm, which is the red line on the bottom here. Because in patients with non-shockable rhythm, the prognosis is pretty dismal with or without cardiogenic shock. So some of our conclusions, the incidence of cardiac arrest in this large STEMI study is 11%, and most of this arrest is due to shockable ventricular fibrillation or tachycardia. The RCA and LAD were equally represented as the culprit artery across all patient groups. Cardiogenic shock has a powerful negative influence on in-hospital and 1-year survival in shockable arrest, but not in shockable arrest. But not in non-shockable arrest. Hospital survival was most favorable in patients who had shockable arrest without cardiogenic shock. They had 85% in hospital survival. The next group was shockable arrest with cardiogenic shock, and then the least favorable group was non-shockable arrest with or without cardiogenic shock, with an in-hospital survival of 41%. So among this large patient cohort, cardiac arrest and or cardiogenic shock accounted for 76% of all hospital deaths. So efforts to further reduce mortality of STEMI must be directed at this population. If you're going to ACC, I will be presenting Saturday morning in Poster Hall C, and Dr. Johnson will be presenting his poster on the same patient cohort on Saturday afternoon. And this is just Dr. Johnson, Dr. Sharkey, and I at my final poster presentation for last summer's internship. And I just want to take a moment to say thank you to Dr. Johnson and Dr. Sharkey, who are my physician mentors for this project. I also have great physician mentors from my time at MHIF with Dr. Larson, Dr. Burke, and Dr. Henry. I also want to thank Ross and Amy, who were my research mentors this past summer, and then also Ross for all of his help getting this poster together. We, of course, can never do it without him. And then also Ava, Jolene, and everyone else involved in the 26 internship program. It was an incredible experience. At this point, we can take any questions. Thank you.
I might have missed it, but did you define what cardiogenic shock was? I mean, you want to make sure you have that somewhere very clear.
Yep. Yeah, and we'll do that. It's one of the metrics that's pulled out into the level 1 database, so it's been adjudicated by whomever is pulling the data from all these STEMI patients that are coming in. But the typical definition of hemodynamic instability with an end organ damage requiring inotropes are the things that they're typically looking for. But we basically queried the database and pulled out anyone who was listed as having cardiogenic shock.
Very nicely done. There's another group, you talk about the group that's non-cardiogenic shock but shockable arrest. Have you looked at the outcomes of those versus the general cohort? Because the thought being that this is a transient event, and if you get over the event, then you should be the same as everyone else, or maybe then you might need prophylaxis if that's not true.
Yeah, no, that's a really good point, and we should do the statistical analysis between those two groups. But when you look, that's absolutely right. When you look at the Kaplan-Meier curves, the survival curves, and you do a landmark analysis at 30 days, there's really no significant difference between the two groups long term. When you take the cardiac arrest shockable rhythm without cardiogenic shock compared to the reference population, yep, no difference.
Can I ask, for the shockable rhythms, were they all VTVF? And in light of that, I might consider, if you pursue publishing this, saying VTVF rather than shockable, because it made my head spin a little bit to say shockable but not shock, shock but not shockable. I get it, but I think it might be a cleaner way to describe some of this.
Yeah, we originally had it stratified as VFVT versus PEA asystole, and then we decided to change that to shockable versus non-shockable. But I think that's a great suggestion, especially up here presenting I feel like I said shock quite a few times in the past 10 minutes, so thank you for that.
Great presentation, by the way. So out of those with shockable rhythm, do you have data on how many of these got ICD?
So that's another really good point. We published last year, the year before, in Heart Rhythm, some ICD data for this cohort of patients. And we plan to cross-reference the databases so that we have ICD information. We just haven't done that yet. So when we go through to the manuscript preparation, we are going to do that.
Great presentation. Has any of this been looked at in other databases?
Yeah, there are other European databases that we can compare to, but this is one of the largest cohorts of patients who've come in with STEMI and cardiac arrest and cardiogenic shock. So I think it's very important data. Thank you.
Okay, next up is a project that, again, started as one of our intern projects. Sarah Tortzen, one of our cardiology fellows, helped. And then Nick Huynh approached us looking for a research project, and we said he had something he could get involved in. So it's my pleasure to invite Nick up here. Nick is a internal medicine resident. He's a native of Twin Cities, went to St. Thomas. He worked as a Fulbright scholar in Sweden and is interested in cardiology. So my pleasure to introduce Nick.
Thank you.
And this is a moderated poster. So for those of you that are not familiar, he'll be in the poster room, but presenting as an oral, his poster on an iPad.
Thank you, Dr. Harris, for the kind introduction. And again, thank you so much for taking time out of your day to make it through this crazy weather to make it to my presentation today. So the topic of my discussion is the clinical and pathologic findings of aortic dissection at autopsy. It is a review of 338 cases over the last 6 decades. I worked on this project with Dr. Thorson, a recently graduated cardiology fellow, and Dr. Harris, and 2 cardiovascular pathologists from United Hospital, Dr. Mackey and Dr. Duncanson. So again, thank you. It's an honor to be here. So aortic dissection is a cardiovascular emergency. It is much less common than acute coronary syndrome, and because of this, diagnosis is often delayed, and in some cases, the diagnosis is not established pre-mortem. We have made significant improvements in diagnostic imaging over the last 30 years, and we now have clinical registries, including the IRAD, that have contributed significantly to our knowledge of this condition over time. In contrast to earlier studies of aortic dissection where autopsies were frequently discussed, contemporary studies of aortic dissection include relatively infrequent autopsy studies, and a reason for this is a significant fall in autopsy rates. The objective of our study was to understand if the clinical risk and the diagnosis of aortic dissection have evolved over time, and second, we sought to evaluate the pathologic findings in a large cardiovascular pathology registry. The registry that we used, the Jesse Edwards Registry of Cardiovascular Disease, is a national referral center for cardiovascular autopsy specimens, and it has been around since the 1950s. We reviewed cases of autopsy with verified evidence of aortic dissection from 1956 to 2015. We analyzed variables that included demographic and clinical data, the type and the extent of the dissection, and the pathologic variables available. For the sake of comparison, we formed 2 cohorts, an early cohort defined as cases from 1956 to 1992, and a current cohort, which is from 1993 to 2015. We chose 1992 as our breakpoint because at that time, it just happened to coincide with the time when the diagnosis of aortic dissection shifted from invasive aortography to non-invasive imaging modalities that include echocardiogram, CT imaging, and MRI. I just have included some pictures of some gross specimens just so you can see what our pathologists saw. In this photo, we have an intimal tear, which is the primary inciting factor of aortic dissection. And this is seen in proximal ascending aorta. Here we have a specimen showing a true lumen and a false lumen that will be seen in our cases. And this is a picture of an adventitial tear with a complete aortic rupture. For our study, a total of 338 patients with aortic dissection were included, of which 167 were seen in the early cohort and 171 were seen in the current cohort. The demographics of acute aortic dissection were predominantly male. 62% of patients were being male with an average age of 60 years old. Overall, 62% of cases were under medical care at the time of death, and the remainder of the cases showed death outside the hospital. 86% of dissections were type A, and 14% were type B. Left ventricular hypertrophy was present in 85% of cases, and hemopericardium was present in 58% of cases. In this figure, we show the cases of aortic dissection while under medical care at the time of death, where the diagnosis of aortic dissection was not established pre-mortem. There was no significant difference between aortic dissection not being diagnosed pre-mortem in the early cohort compared to the current cohort. And so, you see, there's really much that's unchanged over time. Here, this figure is meant to demonstrate the predisposing risk factors responsible for aortic dissection, with the red bars being the early cohort and the blue bars being the current cohort. Cystic medial necrosis, which is a histopathologic finding, was the most common predisposing risk factor, and it was present in almost half the cases. Connective tissue disorder, including Marfan syndrome and Ehlers-Danlos, was present in 10% and 8% of patients, respectively. Bicuspid aortic valve was present in about 15%. Prior cardiovascular surgery was present in about a third of the cases. A history of aortitis was present 8% in both cohorts, and congenital heart disease, mostly coarctation of the aorta, was present in 5% and 7% of cases, respectively. And as you can see, there's no significant difference in comparing the predisposing risk factors from the early cohorts to the current cohort. Acute aortic dissection most commonly involved the ascending aorta, with 68% of the initial intimate tears being seen in the ascending aorta. This is followed by the descending aorta, the aortic root, the aortic arch, and the abdominal aorta. Reasons of cause of death from aortic dissection, the most common reason was acute aortic rupture, and this rupture most commonly occurred in the ascending aorta at 41%, followed by the descending aorta, aortic root, aortic arch, and abdominal aorta. The aortic dissection without rupture leading to death include complications such as stroke, intraoperative complications, shock, sepsis, comprised 21% of cases. Acute myocardial infarction was caused death in 4% of cases. Bowel ischemia, GI bleed, and GI fistula accounted for 3%. And aortic insufficiency was the cause of death in 2% of cases. And there was 12% for which the pathologist was unable to identify a clear etiology of death. In summary, despite significant advancements in diagnostic imaging, aortic dissection remained undiagnosed pre-mortem in greater than 60% of available cases in our cohort studies. The risk for dissections have not changed from the early cohort to the current cohorts. And intimal tear was most frequently seen in the ascending aorta in almost 70% of cases. And the cause of death from aortic dissection was most commonly secondary to an aortic rupture, and this most commonly occurred at the ascending aorta. I'd just like to take a moment to thank Dr. Mackey and Dr. Duncan for the cardiovascular pathologists who worked with me, and thank you, Dr. Harris, for your guidance, and of course, thank you, Ross, for preparing my presentation for you. Please answer any questions. Thank you.
Very nice talk. How did you decide the time point to separate the two groups?
Yep. So 1992 kind of gave us an even breakdown from the early cohort to the current cohort, and at the same time, that was just happening from the literature review. That's when the diagnosis methods shifted at that time. So we tried to find a good breaking point between two cohorts to kind of equalize the samples, and then that just happened to coincide with the timing of it.
Very interesting study. Thank you. I have a question. So most patients died of aortic rupture.
Yes.
And most of them had type A dissection.
Yes.
Which is a surgical emergency. Most of these patients usually get fixed.
Mm-hmm.
Was this an acute setting, or were this patient undergone a repair and then it's still ruptured the ascending aorta?
So we don't have that much available clinical data, but it's just at autopsy, it was a rupture that was seen. Unfortunately, we don't have, especially for the early cohorts, there wasn't that much clinical data just from the data available.
So 2/3 of those under medical care, 2/3 were not diagnosed.
Yeah.
Pre-mortem. And that didn't change between the two intervals, which is kind of interesting if you think about the evolution of the imaging in the early 90s when you started doing CT so much easier, MRI, echo. The diagnosis was still missed more than half the time.
I think it's really, the last conclusion is a little bit problematic, and that is a pathology study. And so the people who were there are dead, right? and so you could have great imaging. I think the real issue is the imaging probably wasn't applied to those who died, and that.
Yep.
So I would somehow manage that.
It's a referral bias problem where, you know, it could be that of people who die and there's enough question that they get sent for an autopsy, 2/3 of them we found that there's a problem, but we don't know what's the denominator, so to speak.
Okay, next we have a contribution from our valve group. I think there's a number of contributions from the valve group at ACC. First of all, I have the pleasure of introducing Marcus Burns and Lynelle Schneider, two of our advanced care providers that are going to present on the minimalist approach to cardiac anesthesia and outcome in patients undergoing transcatheter aortic valve replacement.
Great, thank you, Dr. Harris, for that introduction. We'd like to first start out by thanking the Minneapolis Heart Foundation for the opportunity to be here and share our findings with you today. And we'd also like to recognize the Abbott Northwestern Hospital Foundation for their ongoing support of research and quality improvement initiatives. We'd also like to specially recognize Dr. Siraja and Dr. Gessel. These two gentlemen have been extremely influential in the growth and development that both Lynelle and I have had as advanced practice providers in a short amount of time. They have offered us constant encouragement and wise counsel as we strive to become good stewards of research and leaders in modern clinical advancement in the field of structural heart and valvular heart disease. Transcatheter aortic valve replacement represents one of the most important developments in the field of valvular heart disease management. Since the first TAVR valve was implanted by Cardiology and his colleagues in 2002, the current state of the procedure has taken on some of the fastest and largest leaps ever witnessed in modern medicine.
As you can see here, since the TAVR program's inception in 2011, where we performed 8 TAVRs that year, our annual growth has grown significantly. Last year alone, we performed over 200 TAVRs. With the expansion of TAVR indications to intermediate risk population and even the low risk populations in clinical trials, we are projected to perform over 250 TAVRs this year. Many factors have influenced the growth. The rate of interprocedure complication is falling significantly with a decreased sheath sizes, enhanced pre-procedure imaging, and skilled heart team approach. And most importantly, this distinct maturation of both bioprosthetic devices and operator experience. We have developed a clinical outreach site as well as an extensive referral network that span not only our close neighboring states, but it goes as far as Montana and Florida. These are just a few of the many contributing factors that continue to influence the growth of our program.
So this slide offers a great visual depiction, a little bit facetious, but of what the early days of TAVR looked like. The procedure used to be a very resource-intensive procedure where about 15 to 20 personnel were available. There was a full surgical staff that had an open heart tray set up and ready to go. All patients were subject to general anesthesia as well as intraoperative TEE, and the hospital stay very much mimicked that of a surgical valve replacement. However, as science and technology in TAVR have evolved, the picture on the right is more of an accurate depiction of what we have now been accustomed to. There's been a distinct transformation in the staffing model that we currently use that is instead very much a cath lab-driven procedure like PCI. Only 6 to 7 key personnel are utilized, and although we still directly involve our cardiothoracic surgeons in the surgical preparedness piece has been completely absolved. Gone are the days of invasive lines, Foley catheters, and TEE, as we have now shifted to using sonographer-performed transthoracic imaging, and chiefly a change in anesthetic management, which includes conscious sedation with Versed and fentanyl, and a combination of good localization at the femoral access sites. Now, understanding that this novel technique would require a learning phase, we set out to gain a greater understanding of our experience, our minimalist experience, by paralleling our experience with an ongoing quality improvement initiative.
Although most European centers reveal significantly larger and early adoption of minimally invasive strategies for TAVR, the U.S. experience is quite limited with a large variability. To date, no large randomized studies have compared the standard or conventional TAVR approach with the minimalist invasive approach. To better understand our practice changes, we did a retrospective analysis of the clinical outcomes of our first patients treated with conscious sedation compared to the control 50% of, or 50 patients with general anesthesia.
The baseline characteristics and outcomes, as well as 9-point variable cost breakdowns, were retrospectively compared between the two 50 cohort groups. And what we found was that they were very similar with respect to age, hemodynamic severity of aortic stenosis, symptom status, as well as frailty. The major adverse complications remained the same. All patients in both groups had successful procedures. There were no conversions to open sternotomy, and importantly, 0% of minimalist patients became intolerant to conscious sedation, requiring intubation. By comparison, the minimalist group had statistically significant shorter median procedure times, as well as overall hospital length of stay was reduced almost by a full day. The minimalist approach led to a cost reduction of $2,833 per treated patient. While it's important to note that this figure was derived from total variable costs associated with the procedure and hospitalization, it does not take into account the staffing reductions and more comprehensive supply savings encompassed under reimbursement. We have preliminary data to suggest that this cumulative savings from our initiative are exponentially higher. So in conclusion, the advantage of the minimalist approach compared to the standard approach with general anesthesia includes a shorter length of stay, lower hospital costs, and shorter procedural duration without compromising the safety and efficacy of the procedure. Lynelle and I found that conscious sedation is well tolerated and correlated to positive patient experiences. We personally surveyed each of the 50 patients that underwent conscious sedation for this initiative. And when we talked to them, we asked them Likert-based questions about their pain level, comfort level, physical awareness, and the team's appropriateness on coaching them through the procedure. Additionally, we collected qualitative data and responses. And most importantly, we asked them the question whether or not they would, if afforded the opportunity, would they do the procedure that way again. Overwhelmingly, the results correlated to positive patient experiences with high levels of satisfaction, minimal pain, and all but one patient said that they would do the procedure under conscious sedation again. So our findings demonstrate that the use of the minimalist approach for TAVR can positively impact contribution margins for TAVR, and it has huge implications for the continued growth of this therapy.
As you may be aware, this is our 104-year-old TAVR that went through TAVR using conscious sedation. Kara Levin did a story on her, and it went viral. The Today Show actually put it on their Facebook page, and then she had nearly of 250,000 views. And not only have we impacted her life significantly, we're impacting hundreds of patients' lives. We see it every day, Marcus and I see with further 30 days, and we really are making a difference. So congratulations to all of you as well.
And this is just a quick snapshot of what our poster looks like. We will be presenting our data on Sunday at 9:45 as well. And welcome you guys to come by if you're at ACC. And with that, we'll take any questions that you have.
Just simple. You said that I actually agree with the costing the financial. Is there a way to get that cost?
Yeah, it's quite a complex algorithm, but we're working through that right now, and we're working on the publication as we speak, and that'll be something that will be published very soon.
I might have missed it. How many conversions were there to general anesthesia? And
right. So during the 50, there was 0, actually, for intolerance to conscious sedation.
Then the selection of the patient.
Yeah, so early on, we really, made sure that they didn't have severe COPD or any cognitive defects. But as we progressed in their experience, most of our patients are now done during conscious sedation or doing conscious sedation, about 80% of them.
What we found is it's somewhat paradoxical because actually the sickest patients are the ones that benefit the most from the therapy.
That was a great presentation. Actually, I loved your presentation. I think it's unique to have a different format of presenting, but very well done. I have the same question as John in some way, that it would be nice maybe to highlight, as you said, that the criteria used early on regarding who goes for open versus, moderate versus general anesthesia. And then the other question is, at the same time, in terms of the complications, I may have missed that, but how much lower complications? Well, they were similar, pretty low anyway, but there wasn't any reduction in the complications with the moderate sedation group.
Yes, thank you for pointing that out. And, we kind of broke everything down here, but we found very similar findings between those groups. And again, we were very cautious in our approach because first off, we wanted to make sure that we weren't torturing people going through a major procedure, having just light sedation. But when we looked at the data and the overall picture, it showed that things were very safe and that they were very comparative in their approaches.
Thank you.
Okay, finally, this is our last presentation, and I think we're right on schedule. Ross, do you happen to know how many presentations total that we have at ACC? But we'll be circulating that list later this week. Okay. 40 presentations. That's pretty good. So finally, Lena Trager is going to present. She's a graduate of Washington University with a BA in Classics. She's worked here as a research intern and also as a lead intern, and most recently as a research coordinator. And she's going to be presenting her work on high battery impedance and pacemaker-dependent patients. Lena.
Thanks, Dr. Harris. Thanks, everyone, for being here this morning. So I'm going to be talking about actually pacemaker failure in the pacemaker-dependent population at MHI and our early recognition of some of these device failures. So just some background, the implant rates of cardiac implantable electronic devices, so pacemakers, ICDs, and CRTs, are expected to increase globally within the next several decades. This is in part due to the aging population and greater technological advances. However, with this greater technological advances comes more sophistication and more complex devices that can be more susceptible to device failure and malfunction. So with that, in the past 3 decades, there's been an increased number of device recalls and advisories. From 1990 to 2000, there were actually 52 safety advisories, which impacted a little bit over 500,000 pacemakers and ICDs and cost our U.S. healthcare system $870 million. With that being said, the majority of literature about safety advisories and recalled devices focus on ICDs and lead recalls. ICD
recalls and safety advisories are more common than pacemaker recalls, and obviously a lead extraction procedure has a lot more risk involved, so there's more data and cost analysis about those safety advisories. Complication rates for prophylactic pacemaker replacement, and I guess cost analysis due to advisories is not well defined in the literature currently. So this is the device in question. It's called the InSync III model 8042. It's a Medtronic biventricular pacing device, and it was released in 2003. The last few implants were in about 2011 due to next generation CRT-Ps. Of note, many devices have something called an elective replacement indicator, or an ERI, and in this device in particular, the device resets to 65 beats per minute, and the LV lead becomes disabled. So patients who are dependent on their pacemakers or rely on this CRT therapy may become asymptomatic when the device reaches this ERI. And once it hits ERI, it's supposed to function for 3 months thereafter, so that's important as this story unfolds. So I wanted to present a particular case which is representative of pacemaker failure. A 77-year-old male who is pacemaker dependent. The original indication for the implant was that this patient had permanent or persistent AFib and underwent an AV node ablation with a dual chamber pacemaker for definitive rate control of his atrial arrhythmias. And then 8 years ago, he was upgraded to this CRT-P for progressive left ventricular systolic dysfunction. On a routine device check, there was about 6 months of remaining battery life, so everything looked okay and the voltage was fine. A month and a half later, the device was then at ERI and rapidly dropped to 2.52 volts. At that point, a generator change was scheduled, and actually a week later, the patient fell, reported increased shortness of breath, and there was this interesting finding of discoloration and swelling over the pacemaker site. So the generator change right then and there was not expedited just because there was concern for some type of infectious process. But 5 days later, the patient fainted and was urgently admitted, evaluated for recurrent syncope. And here's just the telemetry tracing. I think, as you can see, there's a 9.2-second pause showing pacemaker failure. There's a loss of output here. There are no pacing spikes, and these beats are not paced, despite this patient having a CRT-P device. And then with device interrogation, the pacemaker battery was found to be at the end of its life, and the patient sustained another asystolic 9.5-second pause with this interrogation. Here's an EKG, which probably looks odd to many of you, and I want to draw your attention to lead V5. So he has chronic AFib, and there's complete heart block here, but there are junctional and ventricular escape beats, and the circles are showing the pacing spikes. However, if you look at the circles with the arrows pointing at them, there is no ventricular depolarization occurring. So this is pacemaker pacing non-capture. There's no ventricular depolarization. And luckily, this patient did have this unstable junctional and ventricular escape beat. But also, there are these interesting T-wave inversions, deep T-wave inversions, which we think represent cardiac memory, which is a phenomenon in which the T waves of these unpaced cardiac cycles are actually tracking the QRS vector from the previously ventricular paced cycles. And obviously could be a concern for ischemia, but we think this is really just representing cardiac memory. So to be continued, the pacing pads were applied and the defibrillator patches were also applied. The patient underwent an emergent device replacement. When the electrocautery was held over the device, it actually intermittently paced, so that was an interesting finding. The leads were disconnected and tested, and the impedance and the threshold of the leads were totally fine, so the leads were not the issue in this case. And the patient was discharged the next day, no complications. This occurred about 2 months before Medtronic issued a safety advisory. And MHI had 4 different patients that had similar case scenarios. And our group brought it to Medtronic and Medtronic engineering to try to figure out the mechanism of their failure. And shortly thereafter, this safety advisory was issued, and it was a recall by the FDA, a Class 2 recall. This was an article from the Star Tribune that kind of detailed our experience with these 4 device failures. And so Class 2 recall in November 2015. The primary issue was found to be high battery impedance, which led to an inability of the device to supply sufficient electrical current, and that led to rapid battery depletion. There was also another issue, which was found to be faulty wire bond connectors, which were found to be of inferior quality and led to loss of output on the affected channels and the leads. The biggest concern for pacemaker failure and unexpected battery failure would be in the pacemaker-dependent population. So they would potentially have a loss of therapy that sustains their life at any given time. And also this flaw could not be fixed with any software or programming updates. That's an important part here. So in terms of our research methods, this was a retrospective chart review. After the recall, a database of subjects who had been implanted with the InSync device was distributed to our group, and we obtained IRB approval for this investigator-initiated research project, and we applied for funding from the foundation, so thanks very much for them. And Dr. Sengupta was our PI. The objective was to track the short-term outcomes and understand analysis of prophylactic replacements and the complication rates involved with these generator changes. So in terms of Medtronic's recommendations, they did not suggest to replace devices in non-dependent patients. And then for pacemaker-dependent patients, they suggested weighing the risk of keeping the device in patients and the complications that could result from early device replacements. And these are numbers from their modeling. This outlines the management process, and I'll just highlight, I guess, in the second bubble. MHI decided to proactively replace all pacemaker-dependent patients, especially those who had a minimum of less than or equal to 6 months of battery life remaining, or those who already had experienced symptomatic episodes of pacemaker failure. And then non-dependent patients were not immediately replaced. They were under a surveillance or monitoring protocol to have remote monitoring or device checks with our clinic every 3 months. Here are some of our outcomes. There were 448 implants at MHI from 2004 to 2011. And of most importance, there were 88 active devices at the time of this recall, and 70 were pacemaker dependent. Our site had a higher malfunction rate of 0.89% than what was reported globally by Medtronic. And we had these 4 confirmed malfunctions at the time of the recall, and 4 that were actually truly therapy compromised at our site. Here are some of the outcomes in terms of replacement. So this actually eliminated reasons why patients would not want to get the device replaced. So 2 patients cited advanced age as reasons to not go ahead with the prophylactic replacement. And 90% of the pacemaker-dependent patients were replaced. And I'll just advance. So in terms of adverse events surrounding these replacement procedures, of the 71 replacements at our site, there was only 1 major adverse event, which was a pocket hematoma that required evacuation and subsequent pocket revision. So that's an extremely low adverse event rate, and there were no deaths as a result of these replacement procedures. In the patients who were just followed under the surveillance guidelines, there were no new therapy compromised events that led to an even earlier device replacement than what was planned. And there's currently 14 active patients with this device at our site who are being followed. So in conclusion, our center had a higher device failure rate than other centers, and we had an aggressive approach for pacemaker-dependent patients to replace the majority of them, and this represented, I guess, our protocol that was more aggressive than Medtronic's recommendations due to the fact that there was a risk to lose therapy in pacemaker-dependent patients. This resulted in a 0% mortality rate, and only 1 complication, major complication. And this suggests that our replacement protocols were safe and effective in response to this safety advisory, and perhaps suggests that there is a need for even more post-FDA approval research registries, which could actually lead to more accurate representation of these failures. And then next steps for this project in specifically would be a cost analysis to see how our replacement guidelines actually were in the long term in the cost analysis way. So I want to say thank you to Dr. Sengupta and the EP physicians here, specifically Mark Corning and the ICD and the PACER clinic, and Melissa Boucher, who helped tremendously with data collection and the MHIF Research Committee and the investigator-initiated folks at MHI. So thank you.
Great job. This is not uncommon. I don't think we have a higher failure rate. It's more how failure is reported otherwise, and we've seen that with everything from leads to devices. You know, most of the data comes from self-reporting and from returned products, and this is just a very underrepresentation of what truly happens. So that we've seen that with everything else, the Fidelis, the Riata, and everything else.
Sure. Yeah. I guess Medtronic and the FDA, they only report on what is reported to them. So I guess we identified these before the safety recall, and that's why we had this higher rate.
When you're making the presentation, someone might ask, and you know, if you're arguing your point. So at the Minneapolis Heart Institute, the device clinic and the patients are a very captive audience. In other words, the devices we put in, most we follow chronically, and our program has, I think there are 13 now clinical nurses that follow devices, and they do something like 23 or 24,000 device follow-ups annually. So that actually explains why, why the data is so solid. So if someone asks you, you should have that figure in mind. It's about 23 or 24,000 visits annually.
Thank you.
And Chuck, when the patients don't come back, they get a series of letters and some phone calls too. Would that be part of the fact that we may have higher rates than other people? We just are trying to track these patients down.
Yeah. And also, in many other centers, you implant a device and the patient goes to their referring physician and they're followed locally by industry. So this is a unique way of following patients all, because we go to all these outreach sites and check them locally, and everything goes to a central location. So and these pacemaker clinic nurses communicate all the time. So if there's a failure, that's seen by one nurse, everybody else will know about it, and then they'll start thinking, well, why is it happening more frequently, and they'll report it to a physician. So just a unique way of following patients.
So amazing to me when you see a patient. I think I had a couple patients last week that never had any follow-up, and I know we're trying to track these guys down.
One very nice presentation, important topic. One minor thing, check your math on the major complication rate. I think 1 in 71 is 1.4%, not 0.01%. So I think you may have added the percent and kept the 1 in 100. So just double check that.
Thank you.
Okay, that's it. Thanks very much for coming.